Okay, let's unpack this. Welcome to the deep dive. We are about to plunge headfirst into the absolutely vital, incredibly intricate machinery that keeps you breathing and alive. Think of it as a deep dive into your inner atmosphere, from the delicate structures in your lungs to the complex ways your body balances oxygen, CO2, and pH, handles crucial electrolytes, and even, well, tries to survive major trauma.
That's right, and we've pulled from a whole stack of detailed sources, lectures covering anatomy, physiology, critical care principles, you name it. Our mission here is really to cut through the complexity, guide you through these systems, and highlight the most important insights and, frankly, some surprising connections. It's about giving you a shortcut, sort of, to truly grasp how these fundamental processes work and why they are just so incredibly important.
So where do we start? It has to be the architecture, right? The basic setup.
Exactly.
The big picture goal is simple enough. Gas exchange, get fresh oxygen in, pull waste carbon dioxide out. And for that crucial swap to happen, you need three things working together: air, blood, and a place for them to meet up.
And the main housing for all of this is your thoracic wall. Picture a sort of cone shape, maybe like a bird cage. It's built from, well, bones, muscles, connective tissue, fascia, skin. The works. Creating a structure that's both rigid enough to protect what's inside, but also flexible enough to expand when you breathe. This framework is essential because it helps maintain that negative pressure inside your chest. That's what pulls air into your lungs.
Okay, the framework, made of bone mostly.
Yeah, the bony part includes 12 pairs of ribs and their costal cartilages. They're anchored by the sternum in the front and 12 thoracic vertebrae in the back. And the ribs themselves have different types. Ribs 1 through 7, sometimes 8, or your true ribs, they attach directly to the sternum, vertebral costal. Then ribs 8 through 10 are false ribs. Their cartilage connects indirectly, kind of piggybacking onto the cartilage of the rib above, vertebrochondral. And ribs 11 and 12, they're floating, no sternum connection at all. They just end in the back muscles. Atypical vertebral-free ribs.
And how they connect allows movement, you mentioned.
Yes, exactly. The joints where the ribs meet the vertebrae, costovertebral and costotransverse, allow for this sort of gliding movement. It lets the ribs rotate slightly upwards and outwards during inspiration. Think pump handle, bucket handle, that kind of analogy. It increases the chest diameter.
Okay, so that's the protective cage. What about the engine, the main muscle driving the whole operation?
That's the diaphragm. It's
Yeah.
this massive domed muscle sheet sitting right below your lungs. It basically separates your chest cavity from your abdominal cavity. It attaches all around the bottom edge of the rib cage, the costal margin, and also connects down to the lumbar spine via these things called crura. The right crust goes down to L1-3, the left to L1-2.
So when it contracts.
It flattens out, pulls downwards. This increases the vertical space in your chest, creating that negative pressure and pulling air in. It's the primary muscle for breathing, no question.
Are there others involved?
Oh, yes. While the diaphragm does the heavy lifting, especially for quiet breathing, you've got accessory muscles. The intercostals between the ribs help maintain the chest wall's tone and rigidity. And then muscles in your neck, like the scales connecting to C1, C7, and the sternocleidomastoid, they can really kick in to help lift the rib cage during forced breathing, like if you're exercising hard or having trouble breathing.
Got it. And the lungs themselves aren't just floating free in there, are they? There's some kind of covering.
No, they're wrapped in the pleura. Think of it as a very thin, slick membrane. It actually has two layers. There's the visceral pleura, stuck right onto the lung surface, even dipping into the fissures between lobes. And then there's the parietal pleura, lining the inside of the chest wall, the mediastinum, and the top of the diaphragm.
In between them.
A tiny potential space, the pleural cavity. It normally contains just a few milliliters of serous fluid. This fluid acts like, well, a lubricant, letting the lungs slide smoothly against the chest wall as you breathe. But critically, it also creates surface tension. It helps hold the lung open, sort of sticking it to the inside of the chest wall, like two wet slides of glass.
Ah, okay. That makes sense.
And there are these little corners or recesses where the pleural layers meet, like down low where the diaphragm meets the ribs, the costodiaphragmatic recess. These are important clinically because that's where excess fluid, like from an infection or heart failure or even air, can collect.
And how does stuff get into the lung, the airways and blood vessels?
Right at the lung root, or hilum, that's where everything enters and leaves. The bronchi, the pulmonary artery and veins, nerves, lymphatics. Here, the visceral pleura reflects back to become the parietal pleura. There's also a little fold extending downwards, the pulmonary ligament, which allows the root some movement during breathing. And one vulnerable spot at the very top of the lung, the apex, actually extends a bit above your collarbone into the neck. It's covered by the cervical pleura and a strengthening membrane, but it's still something to be aware of, say, during central line placement or in trauma.
Fascinating structure. Now let's actually trace the path the air takes inside your lungs from the windpipe down.
Okay, the tracheobronchial tree. It starts with your trachea, your windpipe. You can feel it in your neck. It's held open by C-shaped rings of cartilage, incomplete at the back where the trachealis muscle is. It's lined with respiratory epithelium cells with cilia, those tiny hairs, and goblet cells making mucus. They work together like an escalator to sweep junk upwards.
The mucociliary escalator.
Exactly. Then the trachea splits, bifurcates into the two main bronchi, one for the right lung, one for the left. The right main bronchus is a bit wider and more vertical, which is why inhaled foreign objects tend to end up in the right lung more often. These main bronchi then divide into lobar bronchi, 3 on the right for the 3 lobes, 2 on the left for the 2 lobes, and they just keep branching, smaller and smaller, into segmental bronchi. Each segmental bronchus supplies a specific functional unit of the lung.
And eventually they lose that cartilage.
Yes, that's a key transition. When the airway loses its cartilage support, it's called a bronchiole. Before that, it's a bronchus. This lack of cartilage makes the bronchioles more prone to collapse, especially during forced exhalation, which is a big issue in diseases like asthma or COPD. The smallest conducting airways, where air just travels through, are the terminal bronchioles. Their lining changes to fewer goblet cells, more specialized Clara cells, which are secretory and maybe anti-inflammatory. Simple cuboidal epithelium here.
And then we get to the business end.
Right. After the terminal bronchioles, you enter the respiratory zone. First, the respiratory bronchioles. Their walls start to be interrupted by little outpouchings, alveoli. Gas exchange starts here. Then you get alveolar ducts, which are basically just lined with alveoli, leading into alveolar sacs, which are clusters of these tiny air sacs.
The alveoli, that's where the magic happens.
Millions and millions of them. Their walls are incredibly thin, mostly just a single layer of flat cells, type I pneumocytes. They're surrounded by a dense network of capillaries with equally thin walls. This whole thin structure is the respiratory membrane where air and blood come incredibly close.
And the blood supply.
Deoxygenated blood arrives via branches of the pulmonary artery, which generally travel alongside the airways. They branch down to feed that capillary network around the alveoli. Then, the oxygenated blood collects in the pulmonary veins, which carry it back to the left side of the heart. Interestingly, the veins tend to run separately from the arteries and airways in the connective tissue between lung segments. Oh, and don't forget the bronchial arteries. They're separate, coming off the aorta, and they supply oxygenated blood to the lung tissue itself. The bronchi, the visceral pleura. They keep the lung tissue alive.
Wow. It really is an incredible microscopic factory down there. Given all that complexity, how do we actually check if it's working efficiently? How do we assess function?
That's where pulmonary function tests, or PFTs, come in. They're relatively simple breathing tests, non-invasive, but they give us a huge amount of information about lung status. Are things normal? Is there a pathology?
What can they tell us?
Lots of things. We use them to evaluate symptoms, like shortness of breath or cough, determine the severity of lung disease, track how it's progressing or responding to treatment, assess preoperative risk for certain surgeries, or even screen for subclinical problems in people exposed to lung hazards.
What are the key numbers you look at?
Some key values include peak expiratory flow rate, or PFR, that's the maximum speed you can blow air out. People with asthma often monitor this at home with a peak flow meter. It's good for detecting obstructive disorders like asthma, chronic bronchitis, emphysema. It depends on your gender, height, and age, of course. Then there's forced vital capacity, FVC. That's the total amount of air you can forcefully exhale after taking the absolute deepest breath possible. And a really important one, forced expiratory volume in 1 second, FEV1. That's how much of that FVC you can blast out in the very first second.
And the relationship between those two is important.
Critically important. The ratio of FEV1 to FVC tells you about airflow obstruction. Normally, you can get most of your air out very quickly, so the ratio is high, maybe 75–80% or more. But in obstructive diseases like COPD or asthma, airflow is slow, so the FEV1 is reduced more than the FVC, and that FEV1-FVC ratio drops significantly.
How do you visualize this?
We often use a graph called a flow volume loop. It plots airflow rate against the volume of air in your lungs during a forced breath in and out. Forced expiration is usually shown above the zero line, inspiration below. You can clearly see the PFR, the FVC, and estimate the FEV1 from the curve. A normal loop has a characteristic shape. A loop from someone with COPD looks very different. The peak flow is much lower because of the obstruction. Interestingly, in some cases of severe emphysema, the total volume exhaled, the FVC, might actually be larger than normal. This is because the lungs lose their elastic recoil. They get hyperinflated and trap air.
Okay, so PFTs measure how air moves. That connects to ventilation, right? The actual breathing process.
It does. But we need to be a bit precise. There's minute ventilation. There's just the total volume of air you breathe in and out per minute, tidal volume times respiratory rate. But not all of that air actually participates in gas exchange. Some of it just fills the conducting airways, the trachea, bronchi, where no gas exchange happens. That's anatomical dead space.
So you need to account for that.
Exactly. What really matters for getting oxygen in and CO2 out is alveolar ventilation. That's the amount of fresh air that reaches the alveoli each minute. It's calculated by subtracting the dead space volume from the tidal volume and then multiplying by the respiratory rate. It's a much better indicator of effective ventilation than just minute ventilation.
And this leads to another really critical idea.
Absolutely crucial. Ventilation perfusion balance, or the VQ ratio. You need to match the ventilation V, the airflow getting to the alveoli, with the perfusion Q, the blood flow passing by those alveoli in the capillaries.
Why is that matching so important? Because the gas exchange itself happens by diffusion.
Precisely. Diffusion across that incredibly thin respiratory membrane between the alveolar air and the capillary blood. Gases always move passively down their partial pressure gradient, from high pressure to low pressure.
Partial pressure, just the pressure of one specific gas in the mix.
Yep, like the pressure exerted just by oxygen or just by CO2 in the air you breathe or in your blood. It's proportional to its concentration, as Dalton's law tells us. Think about the atmosphere at sea level. Total pressure is about 760 millimilli Hg. Oxygen is about 21% of that, so its partial pressure, the PO2, is around 160 millimilli Hg. This atmospheric PO2 drives oxygen into your lungs. Inside the alveoli, after mixing with existing air and water vapor, the PO2 is lower, around 100 millimilli Hg.
In the blood arriving at the lungs?
Venous blood arriving from the tissues is low in oxygen, maybe a PO2 of 40 millimilli Hg. So oxygen flows readily from the 100 millimilli Hg in the alveoli into the 40 millimilli Hg in the blood until the blood PO2 equilibrates close to 100 millimilli Hg as it leaves the lungs.
And CO2 goes the other way.
Right. Tissues produce CO2, so tissue PCO2 is high, maybe 46 millimilli Hg. Venous blood reflects this, arriving at the lungs with a PCO2 around 45-46 millimilli Hg. Alveolar air has a very low PCO2, around 40 millimilli Hg, so CO2 diffuses easily out of the blood into the alveoli to be exhaled. Arterial blood leaving the lungs has a PCO2 of about 40 millimilli Hg.
So these gradients drive everything. What else affects how fast diffusion happens?
Several key factors. One is the huge surface area of all those alveoli combined. It's massive, like a tennis court. More area, faster diffusion. Another is the diffusion distance, the thickness of that respiratory membrane. It has to be incredibly thin for efficient exchange. Things like fluid in the lungs, edema, or scarring, fibrosis thicken it and impair diffusion, especially for oxygen. And finally, the solubility of the gas in the membrane and fluid. CO2 is actually much more soluble in water than oxygen, about 20 times more.
That's interesting. What does that mean practically?
I mean, CO2 can diffuse much more easily than O2, even if the membrane is slightly thickened or the pressure gradient isn't huge. Oxygen diffusion is more easily hampered by problems with the membrane.
Okay, let's circle back to that VQ ratio. You said ventilation and perfusion need to be matched.
Yes. The ideal overall VQ ratio for the whole lung is about 0.8. But gravity has an effect, especially when you're standing or sitting upright. Both blood flow, perfusion, and airflow, ventilation, are greater at the base of the lungs compared to the apex. More lung down there, more blood flow, more air movement. However, blood flow increases more dramatically from apex to base than ventilation does. So the VQ ratio isn't uniform.
How does it vary?
At the base, perfusion is very high relative to ventilation, so the VQ ratio is low, maybe less than 0.8. Perfusion exceeds ventilation. At the apex, ventilation is relatively high compared to the lower blood flow, so the VQ ratio is high, maybe greater than 0.8, even up to 3. Ventilation exceeds perfusion.
And problems arise when this balance gets really messed up. VQ mismatch.
Exactly. That's a major cause of low blood oxygen. You could have a perfusion defect. Think of a pulmonary embolism, a blood clot blocking flow to a part of the lung. You have air going into that area, ventilation's okay, but no blood flow, perfusion is 0. This creates physiological dead space, ventilated but not perfused. The VQ ratio in that area becomes effectively infinite.
Or the opposite.
A ventilation defect. This is when you have blood flowing past alveoli, but those alveoli aren't getting enough air. Think of airway obstruction in COPD or asthma or alveoli filled with fluid and pneumonia. Blood flows past, but can't pick up oxygen or drop off CO2 effectively. This creates a functional shunt perfused, but not ventilated. The VQ ratio in that area approaches 0. Both dead space and shunt impair overall gas exchange.
And diffusion problems are separate.
Yes, a diffusion defect is when the membrane itself is thickened, like in pulmonary edema or interstitial lung disease, fibrosis. Ventilation and perfusion might be relatively matched, but oxygen just can't cross the thickened barrier easily. This typically leads to a low arterial PO2, especially during exercise, and an increased difference between the alveolar oxygen level and the arterial oxygen level. The A gradient widens.
Okay, so if any part of this chain fails getting air in, matching air and blood, diffusion, or even carrying oxygen, the tissues suffer. That's hypoxia, right?
Right. Hypoxia just means reduced tissue oxygenation, but it's crucial to understand why it's happening, as there are different types with different causes and implications.
Let's break them down.
Okay, first is hypoxic hypoxia. This is probably the most common type. It means the arterial blood itself has a low partial pressure of oxygen, low PaO2. What causes this? Could be low oxygen in the air you're breathing. Classic example is high altitude. Lower atmospheric pressure means lower inspired PO2. Or you're just not breathing enough hypoventilation, maybe due to drugs or a neurological problem. CO2 builds up, O2 goes down. Or it could be problems within the lungs themselves, that VQ mismatch we just talked about, or a significant diffusion defect. Conditions like pneumonia, COPD, pulmonary edema fall here.
So low oxygen in the artery. What's next?
Second is anemic hypoxia. Here, the arterial PO2 might be perfectly normal, but the blood's ability to carry that oxygen is reduced. The most obvious cause is anemia, not enough red blood cells or hemoglobin. Less hemoglobin means less carrying capacity. Think iron deficiency, kidney failure affecting rich repoietin, B12 deficiency. Or you could have abnormal hemoglobin that doesn't bind oxygen properly, like methemoglobinemia. And the really dangerous one here is carbon monoxide poisoning. CO binds to hemoglobin hundreds of times more tightly than oxygen does.
So it hogs all the seats on the hemoglobin bus.
Exactly. Even low concentrations of CO can drastically reduce the amount of oxygen your blood can carry. And it's insidious, odorless, colorless, tasteless. Your body's oxygen sensors, chemoreceptors, respond to PaO2, which can be normal in CO poisoning, so you don't feel short of breath until it's very severe.
Scary. Okay, type through.
Third is stagnant hypoxia, sometimes called circulatory hypoxia. Here, the arterial blood is oxygenated fine, the carrying capacity is okay, but the blood flows too slow. Delivery is the problem. The classic cause is heart failure. If the heart isn't pumping effectively, low cardiac output, blood moves sluggishly through the tissues. Tissues have more time to extract oxygen, so they take out a larger percentage than usual. This leads to a very low oxygen level in the venous blood returning to the heart. The AV oxygen difference widens significantly.
Which can link back to lung problems, right? Left heart failure causing lung edema.
Precisely. That lung edema then causes hypoxic hypoxia due to diffusion impairment and VQ mismatch. It gets complicated.
And the last type.
Fourth is histotoxic hypoxia. Histo meaning tissue. Here, oxygen delivery to the tissues is adequate. PaO2 is fine, hemoglobin is fine, blood flow is fine, but the tissues themselves are unable to use the oxygen. The classic example is cyanide poisoning. Cyanide blocks a key enzyme in the mitochondria involved in oxidative phosphorylation, the process that uses oxygen to generate ATP energy. So the cells can't use the oxygen delivered to them. Interestingly, because the tissues aren't extracting oxygen, the venous blood returning from them will have an unusually high oxygen level. The AV oxygen difference becomes very narrow.
Fascinating distinctions. Now, beyond oxygen, respiration is also fundamentally linked to another critical balance in the body, pH.
Absolutely fundamental. Maintaining your body's pH within a very, very narrow range, around 7.35 to 7.45, is essential for, well, pretty much everything. Enzymes only work optimally in that range. Cell functions depend on it.
And pH is just a measure of acidity.
It's a measure of hydrogen ion, H+, concentration. A lower pH means more H plus A, which is acidic. A higher pH means fewer H plus A, which is alkaline or basic. The scale is logarithmic, meaning a change of 1 pH unit represents a tenfold change in H plus concentration. The actual H plus concentration is tiny, measured in nanomoles per liter, so using the pH scale just makes the numbers more convenient.
Where do these acids come from?
Your body is constantly producing acids as byproducts of metabolism. The biggest source is carbon dioxide, CO2, from aerobic metabolism. CO2 combines with water to form carbonic acid, H2CO3, which then releases H plus A. This is called a volatile acid because the CO2 can be blown off by the lungs. You also produce non-volatile or fixed acids, like lactic acid, especially during anaerobic metabolism, like intense exercise or shock, and keto acids, in conditions like diabetic ketoacidosis. These can't be exhaled. They need to be buffered in the blood and eventually excreted by the kidneys.
So how does the body keep pH so stable despite all this acid production?
It has three main lines of defense. Are chemical buffers. These are substances in your blood and tissues that can soak up or release H plus almost instantly to minimize pH changes. They don't eliminate the acid, they just temporarily bind it. The most important one in the extracellular fluid is the bicarbonate buffer system, carbonic acid and bicarbonate ions. It's incredibly effective, partly because it's an open system. The CO2 component can be regulated by the lungs, and the bicarbonate component by the kidneys. Proteins, like albumin in plasma and hemoglobin inside red blood cells, are also very important buffers, especially intracellularly. Hemoglobin buffering H+ actually helps it release oxygen to the tissues.
Okay, so buffers are the instant fix. What's next?
Second is respiratory regulation. This kicks in within minutes. Your brainstem had chemoreceptors that sense changes in blood PCO2 and pH. If your blood becomes too acidic, pH drops, maybe because CO2 is high, these receptors trigger an increase in your breathing rate and depth. You blow off more CO2. Removing CO2 shifts the carbonic acid equilibrium, reducing H+ and bringing the pH back up towards normal.
And if you become too alkaline,
Your breathing slows down. You retain more CO2, which increases carbonic acid and H+ stay, lowering the pH back towards normal. It's a rapid way to adjust pH, but it can't fix metabolic problems completely.
so the ultimate control lies elsewhere.
Third, and most powerful for long-term balance, is renal regulation. Your kidneys are the ultimate acid-base regulators, but they're slower, taking hours to days to make significant changes. They have several mechanisms. They reabsorb virtually all the bicarbonate that gets filtered from the blood, preventing loss of this crucial buffer. This happens mainly in the proximal tubule. They can actively secrete H+ into the urine, getting rid of excess acid. This requires buffers in the urine itself, like phosphate, to soak up the H+ so the urine doesn't become too acidic too quickly. This happens more distally. And crucially, during acidosis, the kidneys can actually generate new bicarbonate ions and add them back to the blood, replenishing the buffer system while simultaneously excreting H+ love.
So lungs handle the volatile acid, CO2. Kidneys handle the fixed acids and bicarbonate levels.
Exactly. And the relationship between the respiratory component, PCO2, and the metabolic component, bicarbonate, in determining pH is mathematically described by the Henderson-Hasselbalch equation. It basically says pH depends on the ratio of bicarbonate to dissolved CO2. Understanding this helps interpret arterial blood gas results.
How do you use that to figure out what's wrong?
There's a traditional systematic approach. First, look at the pH. Is it low, acidosis 7.35, or high, alkalosis 7.45? Second, determine the primary cause. Is it respiratory? Look at the PCO2. High PCO2 causes respiratory acidosis. Low PCO2 causes respiratory alkalosis. Or is it metabolic? Look at the bicarbonate HCO3. Low bicarbonate causes metabolic acidosis. High bicarbonate causes metabolic alkalosis. Usually the component that matches the pH change direction is the primary cause.
Then you look for compensation.
Yes. The body always tries to compensate to bring the pH back towards normal using the other system. If the primary problem is respiratory acidosis, find PCO2, the kidneys will compensate by retaining more bicarbonate, metabolic compensation. If the primary problem is metabolic acidosis, low bicarbonate, the lungs will compensate by hyperventilating to blow off CO2, respiratory compensation. Importantly, compensation moves the compensating value in the same direction as the primary change that caused the pH disturbance. For example, in metabolic acidosis, low bicarb causing low pH, compensation involves lowering PCO2.
Can compensation fix the pH completely?
Sometimes it can bring the pH back into the normal range, fully compensated, but often it only partially corrects it, partially compensated. The primary problem is still there. One extra tool, specifically for metabolic acidosis, is calculating the anion gap. It helps figure out the cause of the acidosis by looking at unmeasured anions in the blood. A high anion gap suggests accumulation of acids like lactate or ketones.
Okay, fascinating stuff. Shifting slightly, but still absolutely vital for how cells function, especially nerve and muscle cells. Let's talk electrolyte.
Yeah, electrolyte balance is critical. We're talking about ions charged particles like sodium, potassium, calcium, magnesium, dissolved in your body fluids. We usually measure their concentrations in the extracellular fluid, specifically the blood plasma. But remember, the concentrations inside cells are often very different. Sodium is high outside, potassium is high inside.
Let's start with sodium. What's its main role?
Sodium Nas+ is the most abundant Kh positive ion in the extracellular fluid. It plays a huge role in nerve and muscle function. The rapid influx of sodium is what causes the depolarization phase of an action potential. It also exerts significant osmotic pressure. Water tends to follow sodium, so sodium levels heavily influence your body's fluid balance, plasma volume, and ultimately blood pressure.
Is it regulated?
Oh yes, primarily by hormones acting on the kidneys, especially aldosterone. Aldosterone is released when potassium levels are high, or sodium levels are low, or blood pressure is low via the renin-angiotensin system. It tells the kidneys to reabsorb more sodium, and water follows, and secrete more potassium. So diseases affecting aldosterone, like Addison's disease, low aldosterone, or hyperaldosteronism, high aldosterone, cause predictable Na plus and K plus imbalances.
What happens when sodium levels go wrong? Hyponatremia.
Hyponatremia, low sodium, is actually the most common electrolyte disorder we see. Usually it's hypotonic hyponatremia, meaning low sodium relative to water, causing cells to swell. The manifestations depend on how quickly it develops, but are mostly related to brain effects due to water shifting into brain cells.
Yeah.
Headache, lethargy, confusion. In severe rapid cases, it can cause cerebral edema, seizures, coma, even death.
And high sodium. Hypernatremia.
Hypernatremia is usually due to a deficit of water relative to sodium, essentially, dehydration, losing water without replacing it, or sometimes excessive salt intake without enough water. Risk factors include impaired thirst mechanism, like in the elderly or infants, or limited access to water. Signs include intense thirst, low urine output, dry mucous membranes, and neurological signs like agitation, decreased reflexes, progressing to coma or seizures if severe.
Okay, that's sodium. What about potassium? You mentioned it's high inside cells.
Potassium K+ is the major intracellular cation. While its concentration outside cells is low, small changes in that extracellular potassium level have massive effects on cell excitability. Why? Because potassium plays the primary role in setting the resting membrane potential, RMP, of nerve and muscle cells. The RMP is the baseline electrical charge across the cell membrane when it's not being stimulated. Potassium channels letting K+ leak out are key to establishing this negative charge inside.
So changes mess with that baseline charge.
Exactly. And that's why potassium imbalances are so dangerous, especially for the heart. Let's take hypokalemia, low potassium in the blood. This makes the RMP more negative, hyperpolarization. The cell is further away from the threshold voltage needed to fire an action potential.
So it makes cells less excitable.
Generally, yes. It inhibits action potentials. This manifests as muscle weakness, potentially paralysis, decreased gut motility, ileus. Causes can be decreased intake, increased loss, like with diuretics, vomiting, diarrhea, or shifts of potassium into cells, like with high insulin levels or alkalosis. However, paradoxically, in the heart, low potassium can sometimes increase irritability. It affects specific potassium channels involved in repolarization, potentially leading to early after depolarizations, premature beats, and dangerous arrhythmias like torsades de pointe. You see characteristic ECG changes.
Okay, and the opposite. High potassium. Hyperkalemia.
Hyperkalemia makes the RMP less negative, hypopolarization, moving it closer to the threshold.
So that makes cells more excitable.
Initially, yes. It can cause muscle twitching or spasms. But as potassium gets higher, it actually inactivates sodium channels needed for the upstroke of the action potential, leading to impaired electrical conduction and eventually paralysis. The most dangerous effects are on the heart. It slows conduction, causes characteristic peak T waves on the ECG, widens the QRS complex, and can lead to fatal arrhythmias like ventricular fibrillation or asystole. Causes include decreased excretion. Kidney failure is a big one. Also aldosterone deficiency or blockers like ACE inhibitors, or shifts of potassium out of cells like in acidosis or massive tissue breakdown.
Sounds like you really need to watch potassium closely. Any others we should quickly mention?
Calcium, K++, is obviously vital for bones, but the ionized calcium in the blood is crucial for neuromuscular excitability and muscle contraction, including the heart. Low calcium, hypocalcemia, increases excitability, causing cramps or tetany. High calcium, hypercalcemia, decreases excitability, causing weakness, constipation, and affecting cardiac function. And magnesium, Mg++, is important too. It's involved in tons of enzyme reactions, ATP use, and interacts with calcium and potassium channels. Low magnesium often goes along with low calcium and potassium and causes neuromuscular irritability. High magnesium can block nerve transmission and cause weakness or respiratory depression.
Okay. So we've seen how problems with getting oxygen, dealing with CO2 and pH, and maintaining electrolyte balance can all disrupt how individual tissues and cells work. What happens when the whole system starts to fail, when oxygen delivery to all tissues becomes inadequate?
That's the clinical state we call shock. It's a life-threatening condition defined by inadequate tissue perfusion, basically.
Yeah.
Not enough blood flow and oxygen getting to the organs to meet their metabolic needs. This usually results from a critically low shock pressure, mean arterial pressure, MAP. MEP is the average pressure driving blood flow. Below a certain threshold, often cited around 65-70 millimol Hg, organ perfusion starts to suffer significantly.
And MAP depends on.
Two main things: cardiac output, CO, which is how much blood the heart pumps per minute, heart rate x stroke volume, and total peripheral resistance, TPR, which is the overall resistance to blood flow in the systemic circulation, mainly determined by how constricted or dilated the small arteries, arterioles, are. MAP is roughly CO times TPR. Shock occurs when one or both of these fails critically.
What are the main ways this can happen? The types of shock?
We usually classify shock into a few main categories based on the underlying problem. First, hypovolemic shock, volume loss. This is caused by losing blood volume, hemorrhage from trauma, or fluid volume, severe dehydration, burns. Less volume means less blood returning to the heart, preload, which reduces stroke volume and cardiac output, leading to low MAP.
Makes sense. What else?
Second, cardiogenic shock, pump failure. The heart itself isn't pumping effectively, even if the volume is adequate. Classic cause is a massive heart attack damaging the heart muscle. The heart's contractility is reduced, so CO drops dramatically, causing low MAP. You can think of it as the Frank-Starling curve shifting way down to the right.
Okay, low volume, bad pump. What's the third type?
Third is often grouped as vathogenic or vascular shock, sometimes called distributive shock. Here the problem is widespread vasodilation. Blood vessels relax and open up massively. This causes TPR to plummet. Even if the heart pumps okay initially, the pressure drops. Also, vasodilation causes blood to pool in the veins, reducing venous return and thus CO. So both CO and TPR can be affected.
Examples of that.
Several subtypes here. Neurogenic shock involves loss of sympathetic nervous system tone, maybe from a spinal cord injury or severe pain, leading to vasodilation. Anaphylactic shock is from a severe allergic reaction, releasing histamine and other mediators that cause massive vasodilation and leaky capillaries. And perhaps the most complex and common type seen in ICUs is septic shock. This is caused by overwhelming infection. Bacterial toxins trigger a massive inflammatory response, leading to widespread vasodilation, leaky capillaries, and often direct depression of heart muscle function. It's a real mess.
So when MAP plummets like this, what does the body frantically try to do to compensate?
It mounts a powerful counterattack, primarily driven by the sympathetic nervous system, the fight-or-flight response. Baroreceptors in your major arteries detect the low pressure and send signals to the vasomotor center in the brainstem. This ramps up sympathetic outflow and decreases parasympathetic activity. If pressure gets extremely low, there's even a direct brain response called the cerebral ischemic response that maxes out sympathetic drive.
What does that sympathetic surge do?
Several things, all aimed at raising MAP. It increases heart rate and contractility, trying to boost CO. It constricts veins, venoconstriction, squeezing blood out of the venous reservoirs back towards the heart to increase preload and filling. And it constricts arterioles, vasoconstriction, especially in non-vital areas like skin, gut, kidneys, to increase TPR and redirect blood flow to the heart and brain. It also triggers hormonal responses like renin, angiotensin, aldosterone, and ADH release to retain salt and water.
But these powerful defenses can become part of the problem if the shock isn't reversed quickly.
Exactly. That intense, prolonged vasoconstriction, while trying to save blood pressure, severely reduces blood flow to many organs. This leads to ischemia, oxygen starvation in those tissues, and this sets off vicious cycles. Well, the heart muscle itself becomes ischemic due to poor coronary perfusion, which weakens its pumping ability, further reducing CO and MAP. Cycle 1. The gut and liver become ischemic. This can impair their ability to clear toxins, and damaged gut lining might release bacterial toxins or factors that actually depress heart function. Cycle 2. The kidneys suffer from low perfusion. Acute kidney injury develops, leading to electrolyte imbalances, like that dangerous hyperkalemia we talked about, and fluid overload, which can worsen heart function and cause arrhythmias. Cycle 3. And widespread tissue ischemia leads to anaerobic metabolism and the production of lactic acid. This metabolic acidosis adds to any acidosis from poor CO2 removal, and severe acidosis itself can impair heart contractility and make blood vessels less responsive to the sympathetic system's attempts to constrict them. Cycle 4. This spirals downwards.
And in trauma, this gets even worse, the deadly triad.
Yes. In major trauma, you often see this lethal combination of hypovolemia, from bleeding, hypothermia, getting cold due to exposure and fluid administration, and acidemia, from shock-induced lactic acidosis and poor ventilation. Each one makes the others worse. For example, hypothermia impairs blood clotting and heart function. Acidosis impairs clotting and heart function. It's a nightmare scenario.
And how does shock link back specifically to lung problems like ARDS?
Especially with septic shock, the massive inflammation isn't just causing vasodilation. Those inflammatory mediators circulate and directly damage the capillaries in the lungs. They become leaky, allowing fluid and proteins to pour out of the blood vessels into the interstitial space and even into the alveoli themselves. This causes pulmonary edema, stiff lungs, decreased compliance, severe VQ mismatch, diffusion impairment, that's acute respiratory distress syndrome, or ARDS. Shock, particularly septic shock, is a major risk factor.
Okay, it's clear how interconnected and potentially catastrophic all this is. In a real emergency, like a major trauma case arriving in the ER, how do medical teams possibly sort through this chaos and find the most critical, life-threatening problems right now?
They rely heavily on a structured, systematic approach. It's drilled into emergency responders and trauma teams. The goal is to identify and treat the most immediate threats to life first, in a prioritized sequence, before moving on to anything else. The general framework involves preparation, getting ready before the patient arrives, the primary survey, the rapid initial assessment and intervention, followed by adjuncts, then the secondary survey, more detailed assessment, definitive care planning, and continuous reevaluation.
Let's focus on that primary survey. That's the critical first few minutes.
Absolutely. It's rapid, hands-on, and you treat life threats as you find them. The common mnemonic used is CABCDE. First C is for catastrophic hemorrhage. If there's massive, obvious external bleeding, you control that first. Direct pressure, pack the wound, apply a tourniquet if needed on a limb. Bleeding out is the most common preventable cause of death after injury. Stop the bleeding takes precedence, sometimes even over airway initially.
Okay, bleeding controlled. Then A.
A is for airway with cervical spine protection. Is the airway open and clear? Can the patient talk? Look inside for blood, vomit, foreign objects, swelling. Listen for noisy breathing like gurgling or stridor. If the airway is compromised or potentially compromised, e.g. severe facial trauma, low level of consciousness, you need to secure it, usually with endotracheal intubation, a definitive airway. And critically, you always assume a potential neck, cervical spine injury in trauma patients, especially blunt trauma or if they have altered mental status. You maintain manual inline stabilization of the head and neck until the C-spine can be properly cleared, usually with imaging.
Airway secured, C-spine protected. Next is B.
B is for breathing and ventilation. Is the patient breathing? How fast? How deep? What's their oxygen saturation? Look at the chest. Is it rising symmetrically? Are there any penetrating wounds? Bruising. Paradoxical movement, where a segment of the chest wall sucks in during inspiration. Palpate the chest wall for tenderness, instability, feeling broken ribs move, or subcutaneous emphysema, air crackling under the skin, suggesting air leak from the lung or airway. Auscultate, listen to breath sounds. Are they equal on both sides? Decreased or absent sounds could mean a collapsed lung, pneumothorax, or blood filling the chest, hemothorax.
And you treat specific problems found here immediately.
Yes. An open pneumothorax, sucking chest wound, gets covered immediately with a special three-sided dressing to let trapped air out but not let more in. Flail chest, that paradoxical movement for multiple rib fractures, needs pain control and respiratory support, often including positive pressure ventilation. Pulmonary contusion, bruised lung, also needs supportive care, mainly oxygen and careful fluid management.
Okay, ABC. Then the second C.
Right. The second C is for circulation and hemorrhage control. Now you're assessing for signs of shock systemically. Check heart rate, blood pressure, skin color, temperature, capillary refill time. Look again for any external bleeding missed earlier. But crucially, think about internal bleeding. Where could they be losing blood? Remember, blood on the floor and four more.
4 more places.
Yeah, the chest, hemothorax, the abdomen, intra-abdominal bleeding. The pelvis, pelvic fractures can bleed massively. And the long bones, especially femur fractures, can lose a liter or more of blood into the thigh. You need to rapidly assess these potential spaces, often using adjuncts like ultrasound, EFAST exam, or x-rays. If the patient is in shock, you need large bore IV access immediately and start fluid resuscitation, often with blood products if significant hemorrhage is suspected. You also need to find and stop the source of bleeding. D is for disability. A quick neurological assessment. What's their level of consciousness? Use the Glasgow Coma Scale, GCS. Check their pupils. Are they equal and reactive to light? Are they moving all their limbs symmetrically? Checking for lateralizing signs suggesting a focal brain injury. A GCS score of 8 or less typically indicates a severely impaired level of consciousness and an inability to protect their own airway, reinforcing the need for intubation found in A.
And finally, E.
E is for exposure and environment. You need to fully undress the patient to perform a thorough examination and not miss any injuries. Log roll them carefully, maintaining C-spine precautions to examine their back. But as soon as you've examined an area, cover them back up with warm blankets. Preventing hypothermia is critical. Remember that deadly triad. You need to keep them warm.
Are there specific chest injuries that are so bad they need immediate intervention during that primary survey?
Absolutely. Beyond the open pneumothorax or simple hemothorax, there are three big killers you look for. Tension, pneumothorax. Air gets into the pleural space but can't get out, building up pressure, collapsing the lung, and pushing the heart and major vessels over, mediastinal shift, kinking off blood, return to the heart. Causes severe respiratory distress and shock. Needs immediate needle decompression followed by a chest tube. Massive hemothorax. A huge amount of blood filling the chest cavity, causing respiratory compromise and severe hypovolemic shock. Needs a large chest tube placed immediately to drain the blood and often requires emergency surgery, thoracotomy, to stop the bleeding. Cardiac tamponade. Blood or fluid filling the pericardial sac around the heart, compressing it and preventing it from filling properly, like Beck's triad suggests. Low BP, distended neck veins, muffled heart sounds, causes shock. Needs rapid drainage, usually surgically. Pericardiocentesis might be a temporary measure. Giving 4V fluids can sometimes help temporarily by increasing filling pressure.
So the primary survey is about finding and fixing those immediate threats. What comes next?
Often, during or immediately after the primary survey, you'll use adjuncts like placing an ECG monitor, a pulse oximeter, maybe a urinary catheter if no contraindications, to monitor urine output, a key sign of perfusion, and getting initial x-rays like chest and pelvis, and that focused ultrasound exam, EFAS we mentioned, looking for blood or air in key cavities.
Then, once the patient is relatively stabilized from the immediate life threats, you can take a deeper look.
Exactly. That's the secondary survey. Now you have a bit more time, hopefully, to get a more detailed history and perform a more thorough physical exam. For history, if the patient can talk or if family witnesses are present, you use the AMP-LE mnemonic. Allergies, medications, past medical history, pregnancy, last meal, important if they need surgery, and events environment related to the injury. Then you do a complete head-to-toe physical examination, systematically checking every body region, head, neck, chest, abdomen, pelvis, extremities, back, looking for injuries that might have been missed in the initial rapid assessment. This is especially important if the patient is unresponsive. And you must keep reevaluating their vital signs and overall status constantly.
What happens after all that assessment?
Based on the findings from the primary and secondary surveys and adjuncts, you move towards definitive care and disposition. Does the patient need to go to the operating room immediately? To the intensive care unit, ICU? To a regular ward? Can they be discharged? Procedures identified as necessary, like inserting an intercostal drain, chest tube for pneumothorax or hemothorax, found during the assessment, would be done as part of this process to drain the air or fluid, help the lung re-expand, and restore that negative intrapleural pressure. So as you can see, it's all incredibly interconnected. The respiratory system gets the oxygen in, circulation pumps around, buffers and kidneys handle waste and pH, electrolytes keep the cellular machinery running. And when things go drastically wrong, like in shock or major trauma, the body has these complex compensatory responses, and we have these structured ways, like the trauma assessment, to try and intervene effectively. Understanding one piece really does help you understand the others.
It's truly mind-boggling, the complexity, the resilience, but also how quickly things can unravel, and how critical those systematic approaches are when faced with that kind of chaos. We've talked a lot about how the body adapts, like the responses to high-altitude hypoxia, but thinking about those adaptations and the failure points we see in shock, what do you think are the absolute limits of these systems? How far can the body truly push these adaptations before complete collapse? And could digging deeper into understanding those ultimate limits give us new ways to think about supporting patients right at the edge in critical illness? Something to definitely mull over. Thanks for joining us on this deep dive.